Very warm welcome to all attendees of Cardiovascular Innovations Digital 2020. My name is Thomas Zeller from the University Heart Center Freiburg-Bad Krozingen in Germany. My task is to compare interventional strategies between America and Germany. These are my potential conflicts of interest. I have no particular conflict to disclose related to this presentation. The background of the talk is basically that based on the reimbursement system for endovascular therapy, multiple devices are combined during one interventional procedure in the US. This includes IVUS as additional diagnostic tools. This includes the combination of vessel preparation systems like atherectomy, lithotripsy, and scoring balloon angioplasty. And even DCB angioplasty was following vessel preparation. Frequently, stents are additionally implanted. So Americans waste the money combining too many interventional tools without scientific evidence, and that's the reason why endovascular therapy is so expensive in the US. How do we do it in Germany? IVUS is reserved to scientific purposes. If we use vessel preparation systems, we usually use only one. This is because we have no reimbursement for the combination of different vessel prep systems and following DCB angioplasty, stents are only used in areas of dissection or recoil. Our aim is, in case of vessel prep device use, to avoid the implantation of permanent implants. Let's come back to the problem of the combination of different vessel preparation systems. The key question is, what's the evidence for it? So far, no randomized controlled study is published proving a benefit of any vessel preparation system as an adjunct to drug-coated balloon angioplasty, bare metal stenting, or drug-eluting stent implantation. Even if I believe in some dedicated anatomical situations there should be a benefit. How do we do it in Germany? Femoral popliteal disease first. Simple lesions are pre-dilated with a plain balloon. If it's looking good, we are proceeding with a DCB, and stents are only implanted for focal residual stenosis or dissections. We can even implant a TAC. In case of severe dissection or recoil, we are going to stent implantation. Rationale for the bailout stent strategy is the IMPACT global study showing similar outcomes for lesions stented or left with DCB angioplasty only up to 4 years. In case of bare metal stent implantation, our favorite stent so far is the Biomimics 3-dimensional stent. It's a helical shaped stent device which has shown after 1 year a significant reduction of reintervention rate as compared to a straight nitinol stent. In addition, we found a reduced re-stenosis rate up to 2 years. So the combination of this long-term reduction in re-stenosis rate and the acute benefit of a drug-coated balloon may be beneficial. However, this has to be shown in the future by randomized controlled studies. If we are dealing with calcified lesions, in the meantime we are using lithotripsy with a slightly oversized lithotripsy balloon. If the outcome of predilatation looks good, we are proceeding with a DCB. If there is recoil, we are using either a dedicated calcium stent, the Supera stent, if there was a waste in the balloon, in the lithotripsy balloon. If the balloon was fully opened, we also use drug-eluting stents. The rationale for lithotripsy is the acute luminal gain of 3 mm in calcified lesions as shown in the DISRUPT studies. In case of long complex lesions, we predilate again with a plain balloon, slightly oversized. If the result is looking good, we are going to DCB angioplasty and stenting only on indication. If there is severe dissection or recoil, we have multiple implants available, drug-eluting stent, Supera stent, or the Wireband. In thrombotic lesions, our preference is mechanical thrombectomy with use of Rotarex, which will be available this year in the US, or the Jetstream aspiration atherectomy system. If the acute outcome looks good, we are proceeding with DZB for treatment of residual stenosis. If there is residual thrombus, we proceed with localizes overnight and treatment of residual stenosis the day following the procedure. The Rotarex system is the so far most powerful thrombectomy system, as shown over here in this instant reocclusion of the SFA. This is 8 French Rotarex thrombectomy and the outcome before the use of a DZB. Let's go for infrapopliteal disease treatment. In short lesions, in our definition, it's less than 10 centimeters in lesion length. We prefer the use of a drug-eluting stent or 2 drug-eluting stents. We have devices available up to 48 millimeters nowadays. The rationale for this strategy is that we have 3 randomized controlled studies available showing that drug-eluting stents are superior to either bare metal stent implantation or plain balloon angioplasty. If we are treating long lesions, we predilate with a 1:1 sized plain balloon. If this result looks good, we are going to drug-coated balloon angioplasty, slightly oversized as compared to the reference vessel diameter. In this case, we use only the Litus balloon from Ecotec, which is not commercially available in the US, because this is the only device which has shown to be superior to as compared to plain balloon angioplasty so far. If there is severe dissection, we proceed with focal directional atherectomy followed by DZB angioplasty. We have 2 studies available which show the benefit of Litus DZB angioplasty below the knee. The one is coming from Italy. At 6 months, there was a significant reduced late lumen loss for the entire cohort, which was even more pronounced for total occlusions at 6 months. If you look on the 12 months outcome, you can see that there was a significant reduction in reintervention rate with DZB, and there was just a significant improvement of wound healing. The other study is coming from China, confirming the Italian study outcomes. Again, primary patency at 6 months significantly improved with DZB, and if you look at the 12 months outcome, again, reintervention rate is lower with DZB and ulcer healing is higher, even if it's only numerical for the DZB. There was no concern with regard to amputation rate following DZB angioplasty. So in summary, in the US, more diagnostic tools are used as compared to Germany. The same holds true for the combination of multiple vessel preparation devices. Mainstream for below the knee treatment is atherectomy in the US. In Germany, it's a rare indication. And this is a very important difference, in the US, no clinical effective DZB is available for BTK interventions. I thank you for your attention.